Today I'll be discussing about the management option in the pseudocyst of the pancreas. Somebody has said that most stable thing in this unstable world is change. Therefore, evolution continues. So, ladies and gentlemen, welcome, and I'll be presenting today the management options in the pseudocyst of the pancreas. The cyst, as we know, is a bag filled with the fluid which is lined by a true epithelium. But in pseudocyst, this bag is not lined by a true epithelium. The term pancreatic pseudocyst first was coined by Morgagni way back in 1761. And since then, the management of this pseudocyst is in constant evolution because of the development in the technology and the diagnosis of the cyst, as well as the therapeutic option available as technology progresses in this world. So how we do define pancreatic pseudocyst? The Atlanta International Symposia on Acute Pancreatitis defined pancreatic pseudocyst as an amylase-rich fluid collections contained within the fibrotic pseudo-capsule, usually after 4 to 6 weeks following an attack of acute pancreatitis. That is why any fluid collection which is less than 4 weeks is diagnosed as acute fluid collection, not the pseudocyst. It is diagnosed if it is appearing after 4 weeks following the attack of acute pancreatitis. And if this is infected, it is defined as a pancreatic abscess, not infected pancreatic pseudocyst, as some literature mention the term infected pancreatic pseudocyst, though it is a misnomer as far as the Atlanta definition is concerned. Bradley has published one paper in American Journal of Surgery way back in 1979, and they have, in fact, the group has very nicely described the natural history of the acute pancreatitis sequelae called pseudocyst of the pancreas. What they have noted that in around 40% of the patient of pseudocyst of the pancreas may develop major complication in the form of rupture, abscess, jaundice, or hemorrhage. They also notice around 20% of these patients of pseudocyst of the pancreas resolute in due course of time. One very important observation they made, that if they observe the pseudocyst of more than 7 weeks, then the risk of mortality is higher as compared to the mortality of an elective surgery. Or in fact, this very statement and observation made in this classic paper has resulted in Dogma in the management of pseudocyst of the pancreas, that if the pseudocyst of the pancreas is more than 6 centimeters in size, or if it persisted more than 6 weeks, they requires intervention. And in fact, this dogma continued for last 2 to 3 decades. But in last decade, the things has changed. Because of newer studies has come, new technology has developed, new diagnostic modality, and less invasive and non-invasive therapy for the pseudocyst of the pancreas has developed. And in fact, the paper authored by Vitas and Sowers in Surgery in 1992, and later in Annals of Royal College of Surgeons of England, also Dr. Cherevu has published one very important paper which has in fact demolished the dogma of 6 centimeters and 6 weeks mnemonics in the management of pseudocyst of the pancreas. What they have noticed, that up to 60% of asymptomatic pseudocyst resolved completely irrespective of its size. And they also noticed there is no clear consensus on absolute indication for intervention based on size and time cutoff. So the consensus now has evolved over the time that it is the symptomatic pseudocyst which requires intervention. And the symptoms in the form of pain, in the form of gastric outlet or biliary obstruction, if the patient has developed sepsis or patient has infected cyst, if the patient has pseudoanurysm or hemorrhage, if the pseudocyst is enlarging in size in due course of time, sorry, and if you cannot rule out malignancy in the case of few cysts of the pancreas which was diagnosed as a pseudocyst of the pancreas. Now, what option do we have? The option we have is surgical endoscopic, and percutaneous or radiological. In surgical, we have two options, which is worldwide and also is supposed to be gold standard in few years back, is open surgical method. Now the standard of care as far as surgery is concerned minimally is the surgery in pseudocyst of the pancreas. Second option is endoscopic, which is now the mainstay in the management of pseudocyst pancreas, and few patients actually who are the sicker patient, who are moribund patient, who are in sepsis and they are high risk patient, the percutaneous or radiological management is preferred choice. Now I will deal with surgery first. Now surgery has been considered the gold standard, and most of the therapeutic option is being weighed against the surgery. And surgery basically has two options. One is called internal drainage, also called the cyst-enteric anastomosis, like cyst gastrostomy or cyst-enterostomy in Roux-en-Y. External drainage if the patient has infected cyst. In fact, one of the studies published recently in 2005 has shown that the open surgical drainage, they have combined 14 study and 1032 patients, and in internal drainage they have noticed up to 6% of mortality and 24% of complication rate, and this is the benchmark. The complication of pseudocyst surgery, they also noticed that it is not due to the surgery, but it is due to the underlying state of the pancreatitis and the patient's general health. So the complication of 24% of complication rate in the management of pseudocyst of the pancreas by surgery is not because of surgical procedure as such. It is due to the pancreatitis, the state of pancreatitis, and the patient's condition. Now there is a paradigm shift, as I mentioned before, because of the current advancement in the technique and the technology. In minimally invasive surgery, in therapeutic endoscopy, and in the Mutislice CT scanner for percutaneous approach, one can approach with the pinpoint accuracy in the management of pseudocyst of the pancreas. And nowadays, the open surgery has been pushed to the second line therapy, and more so in the damage control mode. Now, I'll first deal with the minimally invasive options, also called laparoscopy. There are four approaches have been described in the literature, have been practiced all over the world, depending on the expertise available in the particular center. First is the transgastric or anterior gastric gastrostomy. Second is the lesser sac or posterior cyst gastrostomy. Third is intragastric or intraluminal cyst gastrostomy, and fourth is mini laparoscopic intragastric cyst gastrostomy. Basically, this fourth is the same intraluminal cyst gastrostomy with the smaller instrument, which is around 2 to 3 millimeter in size in the diameter. Now I deal with anterior cyst gastrostomy. In fact, this approach has developed very similar to the open approach and was first described in surgical endoscopy in 1994 by Patton et al. And in the same time by another surgeon, which published in Journal of Laparoendoscopics and Surgery. The intraoperative ultrasound is one of the prerequisites of anterior cyst gastrostomy when it was developed by minimally invasive approach. But nowadays, because of accuracy of CT scans, the accuracy of the ultrasound has gained much. The intraoperative ultrasound is indicated in very few cases. Because of the development of harmonic shears and the blood saline devices, the dissection, the surgery, and the less frequent change of instrument during laparoscopic surgery has made it possible to do it with minimally invasive approach. One very small caveat and very important maneuver in the anterior cyst gastrostomy or any cyst gastrostomy is the pseudocyst valve biopsy. Because in few patients, even we diagnosed as a patient who had acute pancreatitis and later developed as the pseudocyst of the pancreas, actually may harbor a cystic malignancy of the pancreas. Now in these group, in fact, as in open approach, the posterior wall of the stomach is stippled or sutured with pseudocyst wall which is matured, and classically described the anastomosis should be 9 cm or more to affect a definitive anastomosis and the drainage of the pseudocyst content into the stomach. One thing you have to note that up to 10% of the patient undergoing interior cyst gastrostomy may require conversion to open surgery. There are different regions and different causes. First is the non-localization of pseudocyst. And in fact, these are the cases where the intraoperative ultrasound is one of the very important equipment during surgery. If the cyst is small enough and one is not able to localize the site of the pseudocyst, the endoscopic ultrasound or laparoscopic ultrasound may actually localize the site of the pseudocyst, and thereby you can fashion a cyst gastrostomy. Then sometimes we may find there is a non-adherence of posterior wall to the stomach to the pseudocyst, and in fact this is one of the prerequisites to do an anterior cyst gastrostomy. To address all these technical challenges, the lesser sac or posterior cyst gastrostomy technique has been developed, and that is why this is also called posterior cyst gastrostomy. And it was developed in 2002 by Mori et al. Which they published this one of the important articles in Journal of Hepatobiliary Pancreatic Surgery. Now, a few things you have to actually see in performing this posterior cyst gastrostomy. What are the basic tenets of this technique? And there are a few basic requirements for this technique. And what are the patients who are eligible to this technique? The first thing, the pseudocyst should be in contact with greater curvature and the posterior wall, so that we can effect a very logical and very viable posterior cyst gastrostomy easily. This is technically simple because you need to divide only the lesser omentum. It has a better visualization because the laparoscopic view, either 0 degree or 30 degree, does not see exactly as we see anteriorly by the open surgery. It is seen in an angle of 120 to 160 degree to the organ. So that is why if this laparoscopy is being used, this posterior cyst gastrostomy appears technically simpler as compared to the anterior cyst gastrostomy. It has a better visualization, obviously, because it does not cut too much of this, it does not cut the anterior wall of the stomach. That's why it has a less bleeding. You can affect a larger anastomosis because you can actually see the whole cyst, almost whole cyst, as well as the whole of the posterior wall of the stomach. And because of the larger anastomosis can be fashioned easily, there is incidence of lesser occlusion and recurrence of the pseudocyst post-surgery. If there is a dense adhesion in the lesser sac, this is the contraindication for posterior cyst gastrostomy. Now, how do you fashion a cyst-jejunectomy? There are a few patients where the pseudocyst of the pancreas not is in relation to the stomach. They are somewhere in the bulging into the transverse mesocolon, maybe in one of the right or left paracolic gutter, or sometime even in the pelvis. And in this group of the patient, one cannot fasten the cyst gastrostomy because the cyst does not lie in relation with the stomach. So in these cases, the jejunum is used to drain this pseudocyst, and that's why the cyst gastrostomy has developed. And most of the time it is loop or roux-en-y anastomosis is performed. And in this case, the cyst-enteric anastomosis usually are of 3 cm, not actually the 9 cm as been advocated in a cyst gastrostomy. But in cyst jejunectomy, the literature and the evidence shows that up to 3 cm of the anastomosis is good enough to effect a very good drainage of the pseudocyst. And because of the cyst wall is very thin and is not very much of strong, because only content of fibrotic tissue, the hand-swing anastomosis is preferred over the staple technique, because in a staple technique sometimes the wall of the pseudocyst may be torn, and in this condition one has to then convert surgery from laparoscopy to the open surgery, because then there is hardly any tissue to do a hand-swing anastomosis by laparoscopic technique. The anastomosis is fashioned in the most dependent part of the pseudocyst to effect a good drainage. Now, the third technique I will describe is intragastric cyst gastrostomy. In fact, it was described way back in 1994 by Michel Gainier, in Mount Sinai and Cornell University in USA, and later it was further been elucidated, and other surgeons have started performing in 1994 and 1999, and they published in Surgical Endoscopy and Journal of Gastrointestinal Endoscopy. Here in this case, the laparoscopic trocar, which is a balloon-tipped trocar, is inserted into the stomach by gastrostomy or under endoscopic guidance. In fact, in these cases, when endoscope has been passed into the stomach during surgery, the stomach is inflated by the gas, and because of the light of the endoscope, you can see the stomach wall through the intra-abdominal wall, especially in thin patient, and by the direct vision and seeing the pressure over the intra-abdominal wall, which can be viewed by the endoscope, one can actually pinpoint where these trocar can be inserted, and usually 2 to 3 balloon tube trocars is put into the stomach by gastrostomy or under the endoscopic guidance. The instrument is placed directly into the stomach through this balloon tube trocar, because balloon work as a hitch which hitches the anterior gastric wall to the anterior abdominal wall, and the surgery is guided by the laparoscope and or endoscope, but nowadays most of the intragastric gastrostomy being performed by laparoscope. Then the cyst gastrostomy is fashioned by conventional and anterior approach, as it been approached by the open method or by laparoscopic method. And usually, if being performed by the conventional laparoscopic method, one can introduce a stapler through one of the trocars and can fashion a cyst gastrostomy easily, as in being performed in the open surgery or in the laparoscopic cyst gastrostomy. But if a 2 mm instrumentation is used to fashion the intragastric cyst gastrostomy, then it is called mini laparoscopic version with only electrocautery and suturing devices is permissible, because a 2 mm instrument, there is no stapler available, there is no harmonic shears available. What is available is basically scissors, Maryland forceps, suturing needle and devices, as well as electrocautery like in hook. So the choice of instrument is very limited in 2 mm of instruments. But that's why one has to be very choosy and has to be very selective to fashion, if you want to practice this method of mini laparoscopic version of the cyst gastrostomy, intragastric cyst gastrostomy, then you have to be very selective. You have to select the patient where the wall of the stomach and the wall of the pseudocyst in apposition, the cyst wall is not very thick, and one can easily perform a hands-on anastomosis by 2 mm instrument with limited instrumentation. Now, what are the complications of minimally invasive surgery of pseudocyst of the pancreas? One review article published in 2007 in Surgical Clinics of North America, they have mentioned the conversion rate from minimally invasive to the open surgery is around 10%. The bleeding complication is around 7%, septic complication around 6%, recurrence is just 3%. The need for second procedure around 5%, and mortality is just over 1%. This is a fantastic figure, and now this is supposed to be the benchmark in the management of pseudocyst of the pancreas. Now, how do you do a percutaneous drainage? The percutaneous drainage, you might be surprised to know that was fashioned way back in 1865, long before the current era of the Mutislice CT scan, the endoscopic ultrasound, the high frequency ultrasound, and all those gamut which are now available to us was not available at that time. And in fact it was performed in a patient of post-traumatic pancreatic pseudocyst. But later, because of its less invasive nature, in 1980s it regained its place. Now, we have 2 types. One is the transcutaneous external drainage, and second is percutaneous transgastric internal drainage. I'll deal with one by one. Now, what is external drainage? Under the guidance of ultrasound, CT scan or MRI, percutaneous external drainage with or without transgastric approach is being performed. Now, there are comparative studies with surgical approach are based on percutaneous see, there are a few things you have to understand, that most of the study which is published comparing the percutaneous technique or the surgical technique, these comparative study, or you can say, are the biased, because percutaneous approach has been preferred in sicker patient, as I've told you before. So that's why these two study which is available in the literature is not comparable. But one can have a glimpse of the things, what is there in the percutaneous approach as compared to the surgical approach. Now in USA, the National Inpatients Sample database, what they have done around more than 8,000 patients underwent percutaneous technique and more than 6,000 patients underwent surgical technique. And this was published in 2005. What they have noticed, that percutaneous techniques has higher mortality rate, as 6% as compared to 3%, and it has longer hospital stays compared to 21 versus 15 days. As I mentioned, that the patient who underwent percutaneous technique are sicker, because they are not fit for surgery. That's why they have been opted to undergo percutaneous or radiological drainage. Now one can also can see whether this studies that the percutaneous approach increased the odds of mortality by 1.4-fold. That is pretty significant. The difference in complication mortality rate persisted even after the correction of the comorbidities. So it is basically the condition of the patient. As I mentioned before, the complication of the management of the cirrhosis of the pancreas is not the maneuver itself. In fact, it is the state of the pancreatitis and the general condition of the patient which decides the mortality in these patients. That's why even if the comorbidity has been corrected, the difference persists, and these differences is higher because the mortality and the morbidity is higher and the complication is higher in the percutaneous as compared to the surgical technique, surgical group. Now one can see the failure rate in percutaneous technique is around 50 to 75%, as well as in surgery group is 19 to 24%. But again, probably if you can say that are not well-selected patient and they are not a coverable patient, because percutaneous technique has been performed in those patients who are not fit to undergo surgery. Or that's why it's not actually say failure rate. In fact, it is probably conversion rate. Now, what is the trick of the trade? Which patient do you have to choose external drainage by radiological method? So the trick is to choose the correct patient. You have to be very selective. Now we all know about the IgDO type of the type 1, type 2 and type 3. In type 1 pseudocyst, the success rate is 82% because in these patients there is no cyst-duct communication exists. In type 2, the success rate of the percutaneous drainage is around 60%. Because in few patients they might have a cyst duct communication, but they don't have any stricture. But in type 3, the patient has a stricture in their main pancreatic duct, and in these patients who has this cyst duct communication as well as the stricture in the main pancreatic duct, the percutaneous drainage is not recommended because these patients develop persistent non-resolving pancreatic fistula. Or that is why they have said that if the patient has pancreatic duct stricture, failure rate can go up to 90%. In chronic pancreatic pseudocyst, percutaneous transgastric internal drainage is most successful, is up to 100%, because these patients, though they might have a ductal cyst communication, but those patients who do not have a stricture, the success rate is around 100%. So this is the internal drainage, because in internal drainage, even if you have a communication, ductal communication, everything is being drained into the duct and into the GI tract. It is not suddenly drained. That is why success rate is 100%. A double J or double mushroom catheter is placed into the gastric lumen and pseudocyst, and removal is endoscopic or spontaneous, and result is comparable to surgery. So how it is being fashioned? Because in these patients, the internal drainage by through the endoscope or by through the percutaneous method, one catheter is introduced into the pseudocyst, which communicate between the pseudocyst and the stomach cavity. And because they have internal drainage, even they have a stricture, even they have ductal connection with the main pancreatic duct, they don't have any fistula because fistula is internal. That's why success rate is around 100%. And in fact, one of the studies published in 1993, they say the result is comparable to surgery. Now, what are the drawbacks of percutaneous technique? First thing, it is the high treatment failure. It is not by choice, it is by force, because this is preferred in the sicker patient who are not fit to undergo surgery. They develop persistent pancreatic fistula because probably we are not sure before performing the percutaneous method that this patient actually has a stricture or actually they have the duct-cyst communication. There is a possibility of infection of the drain tract and pseudocyst, and in these group no cyst wall biopsy is possible, and probably we may be missing few cases of cystic neoplasm and the pancreas. That is one of the important caveat before performing the pseudocyst technique in management of the pseudocyst of the pancreas. So the best policy is to combine both techniques in selected patient. Now, the mainstay in the management of pseudocyst of the pancreas nowadays endoscopic technique. This could be transenteric or transpapillary. Now, the transenteric group, there are two modalities available. One is cyst gastrostomy and another is cyst duodenostomy. Now, there is a few eligibility criteria where the patient can be subjected to the transenteric endoscopic drainage. First is that to succeed, the pseudocyst should be in close approximation where the bulge is, and with a bulge is a must, because through endoscope you can only see the posterior wall of the stomach with a bulge, or that basically signifies the site of the pseudocyst of the pancreas through which that bulge one has to perform a drainage procedure by endoscope. And in 50% of the patient there is no bulge. In these cases, endoscopic ultrasound is used to map the area and contrast is injected to know the anatomy of the cyst. And in these, and maybe one or two stent is being placed through the tract which is made from the posterior wall of the stomach to the pseudocyst, and usually 7 to 10 French is put in there and is kept for the several months. One has to very much cautious to selecting these patients, because in these patients one has to be pretty sure by doing an ultrasound or CT scan that there should be minimal residue. Residue means the cyst content should be serous, should be totally fluid. There should not be should be no necrotic material, or there will be very minimal necrotic material, because the drainage is by a very small 7 to 10 French catheters and stent, not actually a surgical anastomosis of 3 to 9 centimeter. And in these cases the stent are being kept for several months. The long-term success rate is 88 to 97% and recurrence is 5 to 18%, pretty comparable to the surgery as well. One has to be very sure there should not be any necrosis, but because if the necrosis is present, a significant necrosis is present in the cyst cavity, pseudocyst cavity, the failure rate may reach up to 50%. And if the cyst is more distal, that is but more toward the tail of the pancreas where the posterior of the stomach not in a good approximation with the cyst wall, the outcome is worst. The complication rate in different set of literature has shown up to 34%. Mortality is again comparable around 1%. And required for the surgery is up to 15% of this patient, which may need a redo surgery or the damage control surgery, or patient is not responding to the endoscopic management of pseudocyst of the pancreas because of a small tract, a thick collection, or a more necrotic material into the cyst cavity. Now, this transpapillary endoscopic drainage, this is the technique which has been developed in for very selected patient, and especially the patient which has a chronic pancreatitis with pseudocyst. It is indicated only if the duct-cyst communication exists, that is in type 2 and type 3, not in type 1. In 60% of the cases, more in the chronic pancreatitis, it is being used. There is no need for approximation of the cyst wall to any of the GI tract, either the stomach or duodenum or jejunum or colon. Even if it is a thick wall, it doesn't make much difference because you're not actually using those walls for anastomosis. There is no enterotomy is required, and there is no risk of perforation or bleeding as in other technique of the endoscopic drainage of pseudocyst of the pancreas. The disadvantage of this technique, because the stent is pretty narrow, it is minimally lobulated and non-viscous, and little necrosis should be there, because if the lobulation is high or if the content is very viscous, the stent is very narrow, it will be blocked. So this technique will not be effective if the content of the cyst is very viscous or if there is a necrosis present. The success rate of the transpapillary endoscopic drainage is around 90% plus. The recurrence may approach up to 20% and complication up to 12%. Well, what are the options after all discussing all these techniques and the modalities available to us for the management of the cirrhosis of the pancreas? How actually we deal in the real scenario? One has to very sure that these all techniques are available not in a single center. So one has to be pretty sure that though I may give an option to what are the options available to manage this patient, but a center should be very effectively make an algorithm or protocol depending on the expertise available at their center. More so, there is no randomized control study to deal this management in the option of this management option, that which technique is better than others in management of the pseudocyst. So I'll just give an option. What could be the option, and depending on the expertise of your own center, these algorithm or these option can be modified according to the need. If the patient is asymptomatic, does not require anything, just severe observation. If the patient becomes symptomatic, as I told you earlier, or the cyst has enlarging in size, these patients actually require intervention. If the patient has sepsis, the option is external drainage by percutaneous technique or by surgical method. If the patient has a pancreatitis or chronic pancreatitis, then CT and ERCP is must to delineate the ductal anatomy before deciding the modality of treatment of pseudocyst of the chronic pancreatitis. In type 1, endoscopic cyst enterostomy is the primary therapy. In type 2 and type 3, ERCP and stenting in the primary therapy. As I told you earlier, the surgery has been pushed to the second option. The first option nowadays is endoscopic management of the pseudocyst of the pancreas. In very diseased pancreas, like the patient has like in classically described in chronic pancreatitis as the chains of beads of leg in the pancreas, where the multiple structure and dilatation of the main pancreatic duct is available. The stone load is pretty high in the duct or in the parenchyma. Depending on the indication, the lateral pancreatic jejunostomy or LPJ or Whipple's procedure performed if there is biliary obstruction is present with a mass in the pancreatic head, or a distal pancreatectomy if the disease load is pretty high in the tail of the pancreas. If there is an immediate treatment failure following the endoscopic method or recurrence following this technique, then the surgical treatment is the option, and the laparoscopic cyst enterostomy is the gold standard in the management of treatment failure by endoscopic or percutaneous method. Nowadays, the endoscopic treatment, as I told you earlier, is the first line therapy in the management of pseudocyst of the pancreas. The percutaneous modality in selected patients only, because we have told in sicker patients who are not fit to undergo endoscopy and not fit to undergo a surgery, but they require drainage of the pseudocyst, the percutaneous modality has been used and has been advised. And depending on the availability of expertise in a particular center, these algorithms can be modified according to the need of the patient. Surgical therapy is the most definitive, and they also work in a damage control mode, and open surgery is less and less indicated now. As this holds true as of today, but tomorrow we may see a different picture of the management of this cyst. That is why evolution continues. Thank you very much.